one of the few clinicians in this meeting, but I'll try to discuss topics that might be of your interest. So I decided to cover some of the aspects of the state-of-the-art of HIE that have to do with this meeting. I'm thinking of providing a continuum of assessment and neuromonitoring of the baby from fetal to postnatal life, and also to try to provide an introduction to the presentation the presentation of the work that I'm collaborating with in Oxford with Antonia, Chris, and Paul. So hypoxic ischemic encephalopathy is, as you know, a prevalent condition, and it affects between 1 and 3 per 1,000 live births. This means that it affects around 10,000 infants in the European Union each year. It's accountable for around 22% of neonatal deaths worldwide, and also importantly, survivors are at risk for long-term neurodevelopmental disabilities, including cerebral palsy, but not only cerebral palsy, but also other commonly associated deficits. This obviously has a substantial impact on disability-free life expectancy, considering that it affects an individual at the very start of life, and the consequences go on for the duration of the life of this individual. And it's also obviously very costly. So the total lifetime cost of cerebral palsy has been estimated to be somewhere around €1 million or pounds, depending on where you live. And it's also cost for major litigation claims and costly negligence payments. And these are paid either by national health systems or, in turn, the taxpayer, or insurance companies, and in turn, the clinicians who are the clients of these insurance companies. So usually the sequence of events is that we have a profound hypoxic episode, which is followed by hypotension, and with this, with reduced cerebral perfusion, so a combination of hypoxia and ischemia. And what we now know is that neonatal hypoxic ischemic encephalopathy is not a static condition following a hypoxic ischemic insult. It's something that goes on during the first hours and days of life of these babies. So on this slide, you see an illustration of cerebral oxidative metabolism over time based on animal experiments with phosphorus magnetic resonance spectroscopy. And you can see that there's a dramatic drop in the cerebral oxidative metabolism during the hypoxic ischemic event, in what we call the acute energy depletion. And some early cellular death occurs at that point, but not most of it. What happens after this is that if oxygenation is re-established in time, we have a recovery of cerebral oxidative metabolism, and we go on to the so-called latent phase, so phase of partial and temporary recovery. And the duration of this latent phase is calculated based on animal models, and is estimated to be around 6 hours after the hypoxic ischemic insult. After this latent phase comes the secondary energy failure, so many molecular cellular mechanisms leading to delayed cell death, programmed cell death. And some of those mechanisms include excitatory amino acid toxicity, oxidative injury, or inflammation. So this secondary energy failure and the cell death, the programmed cell death that it causes, accounts for most of the disability, most of the abnormal outcomes that follow HIE. Interestingly, there's been a more recent description of the so-called tertiary phase of injury that goes on not for hours or days, but for weeks, months, or even years. And it consists of phenomena such as chronic neuroinflammation, epigenetic modification, or abnormal trophic stimuli, or impaired connectivity. So that's another area for investigation of targets for improving outcomes in this population. So hypothermia is the only neuroprotective strategy that has proven effective clinically, and that is standard of care. And the rationale is that this latent phase represents a window of opportunity to try to stop the process, to try to prevent or ameliorate all those phenomena that occur during the second energy failure, to try to improve outcomes in these infants. So in addition to hypothermia, there are many other neuroprotective treatments that have been tested or are being tested. And one important message is that nowadays these neuroprotective treatments should not be examined or tested alone, but in combination with hypothermia, because hypothermia is nowadays standard of care. On this table, from a recent or relatively recent review, we see some of those neuroprotective strategies that are under investigation or have been investigated, and these include anti-inflammatory and neuroregenerative agents such as EPO or stem cells, antioxidative or anti-inflammatory agents such as melatonin, anti-apoptotic agents, or agents that block the receptors of the excitotoxic amino acids, amongst others. So some variables that we need to take into account. So the first thing is that time of exposure to hypoxia ischemia is often not clearly defined, and it's variable. And we may have a baby that had the hypoxic ischemic insult way before delivery, and therefore we might be already after the latent phase within the secondary stage of injury, and we might be late even if we try to implement neuroprotection immediately after birth. The other thing to say is that the severity of the hypoxic ischemic insult also has an influence on the duration of the latent phase. So also, it might also reduce the chances, the opportunity for implementing neuroprotection effectively. Another interesting debate is the contribution of antepartum versus interpartum factors to hypoxic ischemic encephalopathy. We all know, and part of the reason we're meeting here is that the causal pathways leading to HIE are complex and poorly understood. And part of the problem is the inconsistency with the case definition. So I'm not going to go too much into the terminological debates, neonatal encephalopathy versus hypoxic ischemic encephalopathy, but I think that is one of the contributing factors to the controversial literature in the matter. So if we look at more epidemiological studies that use a broader definition of neonatal encephalopathy, this will include babies with hypoxia ischemia and also babies with other conditions different to hypoxia ischemia, including genetic conditions, congenital and developmental abnormalities. Well, in this larger population of infants that have followed different routes to neonatal encephalopathy, this literature suggests that antepartum events are the main contributing factor. However, case control studies using a more strict definition of hypoxic ischemic encephalopathy, having perinatal asphyxia as necessary criteria, and also using neuroimaging to support acute hypoxic ischemic insult around the time of delivery, show that most cases are associated with a combination of antenatal and intrapartum preceding factors. But those intrapartum factors in multivariable analysis are shown to be the final and necessary pathway leading to HIE. Okay, so patterns of injury and HIE, and I acknowledge that this distinction is based more on neuroimaging than it is on neuropathology, but the idea is that different depths, duration, repetitiveness of insults lead to different patterns of injury in the neonatal brain. So when we have the so-called acute near total asphyxia, then the most vulnerable part of the brain is the central gray matter, the central gray nuclei. These are very active metabolically, have a very high metabolic demand, and they're very, very vulnerable to a very profound episode of hypoxia ischemia. This pattern is the most characteristic of infants with HIE at term. It's common not to have any antenatal or maternal risk factors, and often, and probably not always, but often we can identify an acute interpartum event in this sort of babies. These babies are usually well grown. They're very, very poorly at birth. They're very depressed at birth, and they show more severe clinical encephalopathy. Mortality is as high as 20 to 30%, and the risk of neurodevelopmental disabilities is very high, with a rate of cerebral palsy of between 50 and 75%. The other pattern of injury is the white matter or watershed pattern of injury, where instead of having an acute near total hypoxic ischemic insult, we have prolonged partial asphyxia. And then the areas of the brain that are more vulnerable to that are the border zones between the different territories that are irrigated by the different cerebral arteries, anterior, medial, and cerebral artery. This pattern is less common in reality and in clinical daily practice. Sometimes we do find in this population some pathological background in terms of maternal and obstetric health, and often a single acute event is more difficult to recognize. This pattern is more prevalent in males. IUGR is relatively common in this group of infants. These babies are born in less poor conditions, so better state at birth. Also, the clinical severity of encephalopathy is less, and infection and hypoglycemia are common comorbidities. Mortality is very low, and the risk of cerebral palsy is also low, and the type and the severity of cerebral palsy is also very different from what we see on this other group. However, other abnormal neurological outcomes, including cognitive impairments, behavioral disorders, or postneonatal microcephaly, are common in this population. So what does HI look like to a neonatologist? Well, you have a picture here, and I don't know if you can see it very well, but this is a baby lying on a cooling mattress. So we have water circulating inside the mattress, and we have a rectal probe. So we target a certain rectal temperature, and the machine has an algorithm that changes the temperature in the water so that the rectal temperature is maintained stable and within that narrow range around 33 degrees. The baby is on respiratory support, and you can see that the baby's neurology is abnormal. So the baby is not alert, and the baby is quite floppy with this frog leg position. So this baby has a neurological dysfunction. Typically, the baby would have features of perinatal asphyxia, but that doesn't always happen. So neonatal acidemia and low Apgar scores, and we see the signs of clinical encephalopathy that I just described. So the clinical encephalopathy, by definition, is present from birth, and the dysfunction consists mainly of suppressed level of alertness, and also seizures, but seizures don't appear immediately after birth. Seizures appear later on during the second stage of brain injury. Other features include reduced tone and depressed reflexes, and also difficulty to initiate or maintain respiration. I'll show you a little clip so that you can see more things that are happening around the baby. So this baby has a monitor with the vital signs, temperature, both rectal and esophageal in this case. The baby is bradycardic, partly because of hypothermia. We're monitoring brain oxygenation, which is high. I'll explain a little bit of that later. And we're monitoring brain EEG through a cerebral function monitor, so amplitude integrated EEG. And in this case, the brain activity is suppressed. It has a burst suppression pattern. Okay. Well, thank you. Okay, so clinical assessment of encephalopathy. So that nowadays, from the 70s, the main classification system that has been used to assess clinical severity of encephalopathy is SARTNAT staging. Although, if you read the papers, you will see that most people describe they're using a modified SARTNAT staging system, and that is a little bit problematic because a lot of those modifications haven't been validated. So that's one of the pitfalls. Those modifications usually consist on a simplification. So less clinical items and no EEG items. And SARTNAT classification was a bit more complex, a bit more comprehensive. The other thing to say is that SARTNAT described the stages, the staging system, based on the assessment at 24 hours of age, applied retrospectively. And that's not how we assess these infants nowadays. So we are in quite a hurry to try to define the degree of neurological dysfunction and to try to decide whether this baby meets or no criteria for neuroprotection. So we're applying this within the first 6 hours of life. And this is rather difficult. It's subjective, it's fluctuating, it can progress, and there are many possibilities of misdiagnosis. Usually, so in the current clinical guidelines and in current practice, if we're very strict, moderate and severe encephalopathy are the categories that are eligible for therapeutic hypothermia. However, there is recent literature or review of not so recent literature that suggests that infants with mild encephalopathy don't have such an excellent outcome as what we traditionally thought. And around 25% of those children would have abnormal outcomes at 2 years or later. That, together with possibly medical legal pressures, misdiagnosis, has accounted for a drift in clinical practice, so that it's well known and well described in the literature that more and more babies with mild encephalopathy are being cooled in the neonatal intensive care unit. So apart from the clinical assessment, what other tools do we have to assess injury and to assess time course of neonatal encephalopathy? Well, one of them is EEG, or its partner in the NICUs, which is amplitude integrated EEG. So on this side of the slide, you see multi-channel EEG. You need quite expert neurophysiological input for interpretation of that, and actually using that as a monitoring tool is a little bit challenging, and that is why a lot of the NICUs have this alternative, which is simplification, and therefore you lose information, but it makes it a bit more user-friendly and a bit more practical in terms of use in the units. So amplitude integrated EEG uses less electrodes, less sensors, so you don't have such a good mapping of what's happening all over the brain, but you have just an overall impression of what's happening on the overall cortex or on each hemisphere separately, depending on whether you use only 2 electrodes or 2 electrodes on each hemisphere. So that's one of the elements of simplification of amplitude integrated EEG. The other one is that we have a significant processing of the EEG signal, and we end up having this band, and we look at the bandwidth of that band. So we look at the minimum and maximum amplitude or voltage of the brain activity, and we have certain thresholds, and we can define whether the activity is normal, whether it's moderately suppressed when we have a lower margin, or severely suppressed when both margins are low. We can also have a look at sleep-wake cycling, which has been extensively mentioned in this meeting, and we can also recognize seizures with this sort of monitoring. So amplitude integrated EEG is a very robust predictive tool in this population, but its value has changed in the era of hypothermia. This is a review that we published looking at literature in the pre-hypothermia era and the post-hypothermia era, and whereas in the pre-hypothermia era, the tool had a very high post-test probability right at 24 hours of age. This high post-test probability also happened in the hypothermia era, but this took place with a delay. We didn't reach such high predictive values until around 72 hours of age. This is probably to do with the fact that hypothermia reduces the risk of disability, so the denominator is different, but also to effects of hypothermia on some of the narcotics that we use in these babies, and in turn on the electrical activity of the brain. Another tool that we use in these babies is we measure cerebral oxygen saturation through near-infrared spectroscopy technology. So we place a sensor on the baby's forehead, and we have a light source and a light detector, and we interrogate the tissue right down here. What we look at is blood inside the microvasculature, that's arterioles, capillaries, and venules, and we interrogate more venous blood than arterial blood. So it's normal to have values that are lower than those you would get with arterial oxygen saturation, pulse oximeter. So in HIE, what happens is that there's low cerebral metabolic rates with low oxygen utilization. There's also reperfusion with hyperemia, so what we call luxury perfusion, and also impaired autoregulation with the cerebral blood flow becoming pressure dependent. And all this causes an increase in the regional cerebral oxygen saturation, and this change is correlated with outcome. Heart rate variability, so not something that is used widely in the NICUs, but I think something that would interest you because I think it links well with what you do in the fetus. So there is an association between clinical severity, electrical severity of HIE, and heart rate variability, and also outcomes. And this association remains with therapeutic hypothermia, although in the group of infants with moderate injury, not in a group of babies with severe injury, hypothermia seems to improve heart rate variability. And a little bit about biomarkers. Also, no biomarker has been validated to become established in clinical practice, but there's certainly a lot of research in this field. And by biomarkers, I'm not talking about acidemia or lactate. I agree with Dr. Schifrin's comment that lactate is a risk factor, or acidosis is a risk factor and not an outcome. These biomarkers that I'm listing here are more to do with the pathophysiology, some of the pathophysiological pathways to brain injury, such as inflammatory cytokines or directly neuronal damage. So some of these biomarkers are quite promising and they seem to be relatively good at outcome prediction. But more than that, they allow for kind of a real-time assessment of what's going on in the brain. Early on, they can help us identify babies with significant brain injury or with ongoing brain injury that might benefit from neuroprotection. If we keep on monitoring, we might have some idea about the progression of injury and the response to therapy. More so, these biomarkers may provide information on timing, patterns, and pathways of injury, and in turn enable the recognition of novel neuroprotection targets. So treatment, therapeutic hypothermia, this is what it looks like. So we have a baby in the NICU with a garment. We saw another example earlier lying on a mattress. There are different devices and different companies that sell these devices, but this is one of the ones that is more generally used. And we use this to lower the baby's temperature so that the blood that perfuses the brain is also cold and the brain becomes cooled. We need to initiate this really early on, as early as possible, really, and always within the first 6 hours of life. And I acknowledge that this is a very simplistic approach. For example, 6 hours of life might be too short, or too short for a baby with a more an older event, an event that has happened with sometime before delivery. We prolong it for 72 hours, and this is followed by slow rewarming at a rate of 0.5 centigrade degrees per hour or less. So there are a big number of trials showing the effectiveness and the safety of hypothermia. And this is the summary of the major trials in one of the meta-analyses. So hypothermia is effective in reducing the risk of death or major disability with a risk ratio of 0.75. I want you to notice that of the babies in the hypothermia group in this forest plot, over 200 would have had an abnormal outcome. So there's still room for further developments and further neuroprotection developments in this population. The other thing to say is that when hypothermia was becoming to be evaluated in these trials, there was a question mark about whether it reduced death and not so much disability in survivors, but it actually reduces both things. So we're not just allowing more babies to live with disability, we're also improving outcomes of surviving infants. A bit in a similar way to what has been discussed before about generalized improvements in care, and then not only the application of one single tool. The application of hypothermia has been accompanied by, I think, many improvements in the care of these infants. And I'm old enough to remember that the babies look really different some years ago, in the early 2000s, than what they do now. And probably those changes in practice have also influenced this beneficial effect of hypothermia, both in the trials and in clinical practice. The term neonatal neurocritical care has accompanied the implementation of hypothermia, and I also like the term the neuroprotection change, which comes from a Spanish neonatologist, and refers to all that kind of concatenation of really good care practices that we do from delivery room to discharge. That includes really good resuscitation, implementation of hypothermia really early on, looking after the physiology and detecting and preventing complications that may further impact outcome. Also neuromonitoring and detecting seizures and reducing the seizure burden, doing specialized neuroimaging and specialized follow-up. So talking about neuroimaging, and I hope I'm not going to bore you with some examples of MRI scans, but I think it's important that I do a little bit of introduction to the work that I will present from Oxford. So we I think it is also standard of care, at least in our part of the world, to do an MRI scan between day 5 and day 14 when brain injury would have been established. And in that situation, we usually rely on the conventional sequences of MRI. I put T1 weighted, but we use T1 and T2 weighted MRI. Sometimes we do need to scan earlier, and the typical scenario would be a baby with persistent severe encephalopathy and flat EEG, where we're considering withdrawal of intensive care and offering palliative care to the baby and the family. And we want to use imaging to also support our difficult decision-making process. So in this case, we rely on different MRI sequences, mainly diffusion-weighted imaging, which looks at water molecular motion, or MR spectroscopy, which looks at metabolites in the brain tissue. So the different sequences have a different role at different times, and I think this is a good example here. So if we scan on day 1, we see very little change in any of the sequences. On day 4, the diffusion-weighted imaging and the spectroscopy become much more eloquent. So what we see here is we see the presence of lactate, and we see a lower NAA than normal. NAA is a marker of neuronal integrity. That is a normal compound of the brain metabolite arsenal. And then if we scan later on, we see a pseudo-normalization of these kind of early diagnosis sequences, whereas the injury becomes much more clear, in this case in the central gray matter, on the conventional T1, T2 weighted imaging. So MRI is the best tool to ascertain the pattern and the severity of injury, and with that, the likelihood and the type of disabilities that we could expect. And the determining factors, whether there is basal ganglia and thalamic injury, that is the alteration with a worse prognosis. If this is present in a moderate or severe way, then the risk of cerebral palsy is extremely high. Whereas if it's not present, then we focus on the white matter and the cortex. And if there's injury in these areas, then we estimate a risk of cerebral palsy that is much lower, but other possible abnormal outcomes. The negative predictive value of MRI is, on the other hand, rather high. And has hypothermia affected the predictive value of MRI? Well, in some ways, yes, but it's still a predictive tool. So therapeutic hypothermia has been shown to decrease brain tissue injury on MRI, both in basal ganglia and thalami, white matter, and the internal capsule. But the predictive value remains with these predictive values that you see here. Positive predictive value of 0.776 and negative predictive value of 0.82. So last but not least, I'll summarize. I'll give you a little bit of information, preliminary information about the work that we're doing in Oxford. So I'm working within the overall work that is being done there. I'm working in this HERE study, which is the kind of the application of OXIS in this cohort of infants with HIE. Not only, so it's not a look at that entire population with every possible outcome, but looking at these particular babies with abnormal outcome. So the overall aim is to further develop OXIS by applying it on this cohort of term or nearly term infants with significant HIE. And it's a retrospective analysis of CTG with OXIS with no impact on clinical practice. So we identified 126 infants initially, and some of them were excluded due to mild encephalopathy, not receiving hypothermia. So we tried to focus on the more severe side of the spectrum. 9 infants were preterm, and there was 1 infant that died in delivery room. Another 12 infants were excluding because they had no intrapartum CTG. These are all inborn infants, by the way. So the overall idea, and I'm sorry about the simplicity of my drawing compared to Antonio's sophisticated explanations of deep learning, but the idea is to both test performance and also train the system with data to further develop it. And this is the sort of data that we are working on. We have included or are in the process of including in the database. So we think it's a really nice data set that will serve this purpose and other purposes regarding research in HIE. So we look at antepartum, interpartum, and birth features. We look at clinical encephalopathy, seizures, and neurophysiology, both through amplitude-integrated EEG and conventional multi-channel EEG. Neuroprotection with hypothermia. This is a cohort that was born when hypothermia was already standard of care. And we also look at other end organ effects or comorbidities, neuroimaging, and we're also planning to look at 2-year standardized neurodevelopmental follow-up. So the preliminary analysis that I will present focuses on ascertainment of clinical sensitivity of OXIS, so its ability to detect HIE, and also the association between OXIS and the pattern of injury on MRI, using a classification that's similar to what I've described before. So normal scan, basic ganglia and thalamic injury, watershed injury, or a mixed pattern. So this is these are the characteristics of the cohort. So a little bit, so more boys than girls. That usually happens in this condition and in neonatal care in general, I must say. Gestational age mean of 39 weeks. Birth weight mean of 3.4 kilos. A quarter of infants had a sentinel event. Another quarter of infants had thick meconium, and acidemia in cord blood was present in a third of the cases. There was 9 of the cases died after neonatal admission. So these are the results about OXIS performance. So there were a total of 43.4% cases with alarms on the system. So this sensitivity of 43% compared to 32% of operative deliveries in clinical practice due to abnormal CTG. And it's quite striking to see how this is very similar to the previous findings of Antonia in this larger cohort of over 20,000 women in labor and babies. The most frequent alarm was high decelerative capacity. And another interesting thing to say is that nearly 70% of the alerts were given more than 90 minutes before delivery. Looking at the MRI findings, we also used ultrasound as a way to rule out antenatal brain injury. So a normal brain ultrasound at discharge is what you usually see on perinatal asphyxia, whereas if you see changes on admission, ultrasound, that has to make you suspicious of antenatal injury or something else going on. And that happened in 4 of our cases. 80% of the population had MRIs done, and the reasons for not doing MRIs in this retrospective study were either the baby died before the MRI was performed, or the baby had kind of the milder form of encephalopathy, left hospital really quickly. The MRI was booked as an outpatient, and then there were all sorts of problems with the baby being really unsettled, and then the clinician decided that in retrospect, it was okay not to do the MRI. So a lot of babies had normal scans, and we saw a spread of the different patterns of injury. And with these small numbers, we didn't see an association between the number and the type of OXIS alarms and the neuroimaging patterns of injury. What we did see in this cumulative distribution analysis was an association between abnormal MRI and the number of prolonged decelerations compared to the babies with HI and normal MRI, and also normal controls. So we think that this cohort constitutes a valuable research for continuing developments of OXIS. Its performance is similar to its previous validation and compares well with clinical judgment. However, we aim to increase its sensitivity for timely detection of infants at risk for HIE. We hope that this work will help to further understand the pathophysiological pathways to HIE that can be manifested in the CTG, and how CTG can inform individualized neuroprotective treatment decisions. The analysis of the association with the neurodevelopmental outcomes hopefully will help to ascertain whether computerized data-driven electronic fetal monitoring can prevent long-term neurological morbidity associated with fetal compromise. Thank you very much for your attention.
Very much. Very comprehensive explanation of the neonatal care of babies. We have some time.
Okay, thanks. So, are there any questions? Yeah, just one.
I enjoyed it a lot, and super informative, the introduction and then the results of the study. Thank you so much.
Thank you.
Okay.
It doesn't amplify, it's just for the
Oh, okay.
Oh,
so it looks better. Okay. I apologize if maybe I didn't catch the slide on the results. Did you have a chance to resolve the cohort with MRI in HIE for the the categories that you have shown that have the different outcomes, so the cortical versus the ganglia, and whether the CTG, the cis-ox, has a different.
No, I'll show you. I'll show the slide again if you want. So, a lot of the babies had a normal MRI scan. And if you look at the numbers that go with the different patterns of injury, they're quite small. So partly because of the small sample size, we probably didn't manage to show an association.
Largely, no. You would want to be more non-reactive in the watershed patterns, right? Yeah, well, so far, nothing. Further analysis is due, but that's what I wanted to see.
I would expect with brainstem is effective.
Me too. And I've looked at them, of course, individually by eye, because they are, I've looked at them with all kinds of metrics, not only with Optim 1.5. It's a further work. We'll do a lot more work. It's preliminary findings, nothing that associate with different patterns than others.
Can you make a challenge for staff to rank it up?
Well, if you define the challenge well, please. I'm not sure what the challenge is. To share the data with.
Well, no. The question is, so if I may, yeah. So you've got the recordings, you've got the outcomes. Can we connect them? Is there something in the signature?
Yeah, you mean to share the data and out.
Yeah, kind of a localized. But again, maybe
It's something to consider.
Yeah, along the same lines about the hypothesis that there's a relationship between the MRI about the hypothesis that there's a relationship between the CTG patterns and the MRI postnatal imagery is clearly you need bigger numbers, I guess, to establish that. But are there good physiological reasons to believe that there might be different patterns in the MRI?
So I think a lot of the literature about patterns of injury in relation to depth and repetitiveness of injury are a little bit dogmatic, I think. After reading it, I think that it's a lot of kind of neuroimaging and kind of self-fulfilling prophecy. But the theory or the small evidence is that different areas of the brain are vulnerable to different pathways, different mechanisms of injury. So the hypothesis is that that would reflect on the CTG. I don't know if I answered your question.
Well, I'm going. Yeah, I'll take it too. Can I just ask you a very simple question when I'm on the way? If you have, we know about neonatal encephalopathy, the syndrome, the clinical syndrome, and it's shown that some of the cases that you later on classify as hypoxic ischemic, you don't have the proof of acidosis either in the cord blood or in the first hours of newborn of birth. So what do you use to classify them as hypoxic ischemia?
So the data about the acidosis comes from cord blood. So quite often we see a baby that has normalish cord gases, but then on the first hour of life they develop acidosis, and we have a couple of cases like that tomorrow this afternoon. Sorry, in the case-based discussion. So that's one part of the answer. So sometimes you see further acidosis if you do the bloods later on. Yeah.
Okay. So but you do have some documentation of
yeah,
acidosis, but it's not a birth.
Yeah,
it's like,
and then the other thing. Sorry. Yeah, and that's the other thing. So all the protocols for decision making about cooling or not cooling, so they're divided in two boxes. One of them is there an indication of hypoxia ischemia, and two is the baby encephalopathic. And in this first box, acidosis is not the only category. So if the baby had an APGAR score of less than 5 at 5 minutes, or they needed resuscitation for more than 10 minutes, so the other one is acidosis or a base excess of more than 17, a base deficit of more than 17. So if you fulfill one of those categories, then you do meet criteria A, as we would say.
No, but that's fine. That's criteria for doing cooling. But how do you put a stamp saying this is HIE, this is not HIE, this is encephalopathy of another cause, genetic metabolic?
Well, so yeah, so a lot of the babies are typical, and others are not. And sometimes we do, so this is a clinical reality. So sometimes you end up having a baby with a metabolic condition that mimics HIE, or a baby with neuromuscular disease that was born floppy. We exclude this, so that retrospectively it's easy to exclude those babies. But if you, in a prospective clinical practice, sometimes you face those dilemmas, that's for sure.
Is it it's a clinical diagnosis? If you do not have the acidosis, it can be a clinical diagnosis of HIE or not?
I think it's the exception more than the rule, but we do have some babies that end up with diagnosis of HIE with not with acidosis that doesn't reach that threshold of less than 7.
Mm-hmm. Okay, so you go to other data. Okay, thanks.
Thanks. And thank you for that. I was wondering if you could address, I think there was an exclusion criteria, if I saw it on the slide, of under 37 weeks for this particular study. Is that correct?
Under 36 weeks, yes.
Yes. Was that because of a power issue? Are the phenotypes very different if it happens early on? And then that also would inform what one might look for, the timing of the CTG that you're looking for as a biomarker. So
that population of preterm infants, including late preterm infants, have been excluded from the randomized controlled trials, for example. And that's what. So the gestation age criteria is part of the clinical decision-making process, and partly is because exactly what you said about the neurological phenotype being very different and that population being quite unique. So both for clinical practice reasons and for kind of data clarity, we exclude that population of late preterm infants. Yes.
Okay. As Austin, I think we really need to keep it very short. Is that okay?
Yeah, you need to be. You're next.
And very quickly, so thank you very much for your great talk. It was very comprehensive, as it was said. I'm particularly very quickly. Sorry. In those in that population without a CTG at birth, were any particular CTG pattern identified in those babies?
We haven't looked into that, and that's one of the things we
because
need to
apparently the mechanism is there and it's ongoing.
Yeah.
And I would be very interested.
Yeah. Okay. Thank you.
Okay. So I think we really need to move on. I promised Antonio that we would not be overrunning. So it's our next speaker is Austin Gugumadou from St. George's. Non-reactive fetal heart rate patterns. Yeah, Austin. It wasn't you.
I thought I should exit since I've had the applause. Thank you. Yes.
Okay, yes.
Now,
Yes.
one, no,
Spam.
it's not here. Okay. It's here. Okay. It's here. This one?
Yeah.
Test? Yes. Okay. Just let me test. Okay, the printer is working. Okay. Just I have to put the microphone. No. Okay. Wait. Okay. It's okay.
Yeah, I got it.